So we are delighted to welcome Dr. Jessica Farrell with us today. Um, some of you may have seen a presentation of hers several years ago. I think it was our 20th or 10th anniversary. That's right, 10th anniversary. I'm dating myself. And she's got fabulous information to share with you. So hopefully you'll learn some new things and reinforce some things that maybe you needed to hear. So she is a distinguished clinical pharmacist in rheumatology at Albany Medical Center and an associate professor of Albany College of Pharmacy and Health Sciences. She has over 15 years of experience, although I probably have to update that periodically, right? Um, and provides a range of clinical and pharmacy services, including pharmacotherapy, consultations, and patient counseling. And I know this is a very patient-centered individual, very compassionate, and has really thinks about what she can do to help make it easier for us to get what we need as scleroderma patients. Um, she completed her Pharm.D degree at Albany College of Pharmacy and Health Sciences and her residency at Inglewood Hospital and Medical Center in New Jersey. And she holds a lot of things, the American Pharmacists Association's immunization certification. I know all the things. And she's been very much involved with a variety of aspects, including research looking at drug therapy and autoimmune diseases, including rheumatoid arthritis and scleroderma and lupus. She's definitely highly engaged in scleroderma community through the National Scleroderma Foundation and the Stephan Scleroderma and Dagos Disease Foundation. I've had a chance to work with her in a variety of places. She's very dedicated, learned so much from her. So I'm going to hand it over to you, Jessica, for you to start, and I am going to make sure it's off. So you test your mic real quick.
We're good? Yeah, I think so.
Yeah,
A little echoey. Let me turn the volume down just to.
Yeah,
How's this? Is that better?
it's a little loud, isn't it?
Okay. How about, is this good? Everyone okay? Okay. I don't want it to be echoey. Thank you, Karen. So welcome everyone. So I am honored to be here for a second time. The last time I was here was in 2020, and it was my last trip with my family before the world shut down. So my daughter was not even walking yet, and now she's 7. So it doesn't feel like it was that long ago, but I had such a lovely time when I was here last time, and I'm very, very happy to be back. And the hospitality is amazing. I had a lovely time since I've been here. So as Karen mentioned, my role is very unique. It's not incredibly common for a pharmacist to be embedded in a rheumatology clinic there, and especially in a scleroderma clinic. And when I started, I really, I wasn't looking for rheumatology. It found me, and I found myself working with a scleroderma specialist who asked me to spend Tuesdays were his scleroderma clinic, and I spent time with him. He mentored me. And 17 years later, here I am. I've been very involved with the Scleroderma Foundation, National Foundation. I'm on the board and have been involved my entire career. Locally, we have an amazing interprofessional education event that the Stephan Foundation, which is our local Scleroderma Foundation, has spearheaded, where we have patients that are educators. So we have an interprofessional event where we have pharmacy students, nursing students, PT, OT, psych, med students. They all come together, and we do it virtually now, but they get in a Zoom room with a patient, and they learn directly from a scleroderma patient. And it's so amazing and so inspiring. And the feedback that I get from the students after is just, I get teary-eyed sometimes because it's just so amazing how much they learn from you. So thank you all for anyone who has been an educator to any healthcare provider. It's an amazing thing that you're doing. So, all right. Yes, okay. I'm in frame. Okay. All right, so is this gonna work, Karen? No, let me just scoot this over. Oh, yeah. There we go. Okay. So I don't have a ton of slides, so I really wanted to make sure that I left time for questions. Like I said, I've been involved with scleroderma patients and helping them with medication-related problems and access for my entire career. So 17 years now, Karen. So, which is not an easy thing and can get very discouraging. But I do my best to work with my individual patients. So here are a handful of questions that come up very regularly. Some of these questions may pertain to you, some may not. But I will do my best to answer questions, recognizing that you and your physician and your providers will, can talk about this for you individually. But the first question that I get a lot of time is, how do I time my medications? And how I have a lot of patients that stress about this because they want to make sure that they're taking them all, they're not forgetting them, that they're taking them appropriately. Some of them have to be taken with food, some not. Acids can affect things. So we're going to go through some of that. We'll also talk about vaccines. So I think in the post-COVID world, there were a lot of questions about how to time medications, our medications in rheumatology, specifically around vaccinations. So I'm going to simplify some things for you if you still have those questions. We do a lot of osteoporosis management for our patients, and there's lots of myths and lots of questions that we hear about those medications. For patients that are on Rituxan, I often hear, how long do I have to be on this? Can I be on this for a long time? Is it safe? We use a lot of immunoglobulin, so IVIG is something that we use in a lot of different rheumatic diseases and for patients with overlap conditions too. So that's something I get questions about. And then lastly, we'll talk a little bit about access and Medicare changes and high cost therapies and some resources for you. So before I get started, I felt I needed to kind of just give a brief overview of all the medications that a patient with scleroderma could potentially be on, some most common ones. So you as an individual patient may not be on any of these, or you may be on one or two, but we have medications that are considered to be disease modifying. So disease modifying meaning they can slow the progression of the disease. And those drugs include drugs like mycophenolate mofetil or Cellcept, or mycophenolic acid or Myfortic, hydroxychloroquine, methotrexate, tocilizumab, rituximab, and hopefully in the next few years we'll have some more of those therapies too to list out. And then most patients with scleroderma are on some type of antacid, so proton pump inhibitors like Protonix and omeprazole. Sometimes we're on blood pressure medications, different ones like ACEs and ARBs and calcium channel blockers, so lisinopril, losartan, amlodipine, nifedipine. These are medications that can help open up the blood vessels and help with Raynaud's to some degree. Vasodilators that can help with both Raynaud's and ulcers and also the lungs. So medications that are called phosphodiesterase inhibitors like tadalafil and sildenafil. Bosatin is a medication that opens up blood vessels too. It's less commonly used, but can help with ulcer healing sometimes. Prednisone, methylprednisolone. Some patients with scleroderma shouldn't be on these medications or be use them very sparingly, but some patients can be on them. Medications for the GI tract that can either help motility or either speed things up or slow things down, depending on the patient's needs. If there's overgrowth of bacteria in the gut, there's antibiotics that we can be on, rifaximin being one of them, and then some other pulmonary hypertension medications that are listed there. All right, so let's talk about how do we time our medications. So when you get the medications, the handout from the pharmacy, generally it's incredibly overwhelming and you need a magnifying glass to read it. I just started to do this. So I know that Rick wanted to put me to borrow his glasses at dinner last night. So those handouts from the pharmacy can have so much information and it's really not focused for you as an individual patient. It's very general. It's required by the FDA. So it can be very overwhelming. The Scleroderma Foundation does have some handouts on their website that can be helpful. I have a handful of different videos that are on YouTube through the Scleroderma Foundation that you could go back to and listen to if you wanted more details about specific medications. Levothyroxine, although not used just for scleroderma, it's used for hypothyroidism, is a common overlap condition, and it does require very specific timing. So it needs to be taken at 30 to 60 minutes before breakfast and by itself. So that one has very specific timing that needs to be considered. Mycophenolate mofetil or CellCept requires an acidic environment to be absorbed well. So it really should be timed around the antacid, like the proton pump inhibitor, like Protonix, pantoprazole, omeprazole, these medications. And then prednisone also is one of these ones that really should be taken early in the morning, because if we take it late in the day, it can cause some issues with our sleep. And some of these medications do need to be taken or should be taken with food so it doesn't bother the stomach. And I have an example kind of layout for you if you were on all of these medications. Hydroxychloroquine can upset the stomach a little bit. So again, taking it with food. Amlodipine we don't really need to worry about timing with food or other medications. Tadalafil doesn't really require any timing related to other medications or food either. And then rifaximin, again, doesn't really absorb. So it really we don't have to worry about timing in terms of food. But here's kind of a layout of what the timing would look like if you were to take all of these medications, if you happen to be on all of these medications for the day. And this can be overwhelming. This is like a part-time job, right? To be able to time all of this out. So, while some medications do really need to be taken a specific way, do your best. If we're able to space them out, if you don't get up at 6:30 in the morning, that's okay. If 7:30, trying to do your best to manipulate the timing so that we can get the most out of the medications that we're taking. So you'll see that levothyroxine is one of those that you take first thing in the morning, and then about 60 minutes later, you can take the mycophenolate mofetil, that one that needs an acidic environment. And the one thing that I wish they would stop putting on the pharmacy labels, but it always says on the proton pump inhibitor like omeprazole and Protonix and pantoprazole that you have to take it 30 minutes before food. And while that is the optimal way to take it, if you weren't on a lot of other medications, it's supposed to help with acid for the first meal of the day. It still works if you take it with food and take it outside of the 30 minutes before food. So that's one that you can certainly play around with. It does decrease the acid in the stomach. So if you are on CellCept, we really want to try to get that first dose when there is a little bit of acid in the stomach. And then prednisone with breakfast in the morning, hydroxychloroquine and amlodipine and pantoprazole. We're going to talk a little bit about osteoporosis medications and supplements, but if you are on acid reducer like pantoprazole, it's really important that the type of calcium that you're taking is calcium citrate, because it doesn't require an acidic environment in the gut to be absorbed. So while if you're taking calcium carbonate, you may be absorbing a little bit, but the best option for you is to take that calcium citrate formulation. And I have a couple of slides on that too. Tadalafil, if you're on that for Raynaud's and you're only taking it once a day, taking it as needed or in the middle of the day. Rifaximin does need to be taken 3 times a day, or 2 to 3 times a day. So if you're on that for a period of time, generally that's not a chronic medication. We're just using it for short periods of time. And then your second dose of mycophenolate at around 6 p.m. And then if you can squeeze in your last dose of calcium citrate at 10 p.m. I try not to be awake at 10 p.m., but so I'm not sure about some of you, but doing your best to squeeze all these medications in and finding what works best for your schedule. So I think that's what I really want to emphasize. So try not to stress too much about it, but if you are on all these medications, this is kind of the ideal way that you could try to fit it in to your day. All right, so we're going to move on to vaccination. So there's a lot of information on some of these slides, so don't get overwhelmed. but this question still comes up. I still get phone calls from patients during COVID. There was lots and lots of concerns for our patients with rheumatic diseases. So if you were diagnosed with scleroderma post-COVID, you might not be aware of this, but there were lots and lots of questions about like, how do we time our medications that affect the immune system around vaccines to get the optimal response? So the American College of Rheumatology was actually working on vaccine guidelines prior to COVID, and they continued to work on them and didn't publish them until 2022 because they really wanted to make sure that they were being realistic and being evidence-based. So what that means is that there's actual studies to support manipulating our medications around vaccines for optimal response. And during COVID time, there really was very limited data, and we were making a lot of extrapolations or guessing in terms of how we think timing would affect vaccine response. So this guideline was published in 22. It really just basically says that all patients that are immunosuppressed or immunocompromised, patients with rheumatic disease, should be vaccinated, and it's highly recommended, obviously, for flu vaccine, pneumococcal vaccine, zoster vaccine. Some of our medications that we use in rheumatology can increase the risk for shingles, so they have updated the recommendations for the shingles vaccine to over the age of 18. So, and if they are immunocompromised, so there isn't kind of an age limit on that anymore, and that's strongly recommended. And then for patients that fit in kind of the window of 26 to 45, an HPV vaccine. So these are kind of overarching recommendations. All right, so what they did was, because I mentioned it got very complicated during COVID times in terms of timing medications, they simplified things, which is very helpful. So really, the couple medications that we're really worried about and we have evidence to show that can affect vaccine response are methotrexate and rituximab. Those drugs have been shown in multiple studies to affect vaccine response. So methotrexate is one that we use for joints and sometimes skin and scleroderma, and we use it a lot in other rheumatic diseases. It has been shown in some studies to decrease the response to vaccines, to specifically flu vaccine. So what the recommendation is that if they are if you're able to hold that medication for 2 weeks after the vaccine, so you get your vaccine and then the next 2 doses of methotrexate, you hold that. And if you have a disease that is stable enough that you are able to do that and not start to feel achy, and your doctor's okay with that, then that is the recommendation, to hold it after the flu vaccine so that you can get the best vaccine response and get a stronger, more robust response. Now, I already mentioned rituximab. There is data to support that it affects vaccine response, but the problem with Rituxan is that it is only dosed every 6 months. So if you are on a cycle of every 6-month dosing and the flu vaccine time frame, so the fall, comes in the middle of that, we don't want you to not get the flu vaccine because of the Rituxan. We're just going to give the Rituxan so that we can get some vaccine response to the flu, and we'll worry about manipulating the Rituxan later. Some providers, so if your next dose of Rituxan is in the fall, then we would try to wait till right before that dose of Rituxan. And that's where that vaccine, the second column about timing before other non-live vaccines comes in. So ideally, if you have to get a booster for something or another type of vaccine, like the shingles vaccine, and you're on rituximab, we're going to wait until right before your next dose. And that allows for the most robust immune response to the vaccination, so that we're not just giving you a vaccine and not having it be effective. So other medications that, because there's limited evidence and we want to keep it simple, we are just going to continue those other medications, so you're not going to manipulate them. So everyone following me? And obviously, there's many in the room that this might not pertain to, but if it does. And then if you happen to be on prednisone for a period of time, so the magic number with prednisone is more than 20 milligrams, which in general, we try to really not use that much, and especially in scleroderma. But that magic number is over 20. So if you're on more than 20 milligrams of prednisone, we generally want you to wait till you're on lower doses to get a vaccine response. So if it's not flu vaccine, again, they simplified it because of the timing that it's important to get the flu vaccine in the fall, and we don't want to miss the opportunity to vaccinate. So that's why they simplified those recommendations. But if you notice that very right-hand column, the last one that says defer, if you need a shingles vaccine and you're on more than 20 milligrams of prednisone, we would want to wait till you're on a lower dose so that we can get a better immune response. Okay, moving on to osteoporosis. What time do I have till, Karen? Or 9:45. Yes, okay. All right, so osteoporosis. So this might really pertain to most of you in the room. So hopefully you'll find this information helpful. So osteoporosis. So there are a lot of different questions and myths around the medications that we use for osteoporosis. Calcium and vitamin D intake is very important. I already mentioned that if you are on an acid like Protonix, pantoprazole, omeprazole, any of those medications, that we want you to be using a supplement that's going to be absorbed better, which is calcium citrate. And the most common version that you'll find on the shelves, is both calcium carbonate and citrate, but who's walked into CVS and looked at the supplement aisle? All those tags too. Like, is everything on sale all the time? I guess so. And I used to work there when I was an intern. So it's very hard I walk in there as a pharmacist and I'm overwhelmed. So I feel you if you feel that way too. So you really have to, I have a couple pictures of some labels that will help you. So calcium citrate. Ideally, we like to say that if your requirement is about 1,200 milligrams of calcium a day, how much calcium are you getting from your food? So if you are fairly consistent and you drink milk or almond milk or yogurt or whatever foods that you eat regularly, and you eat that most days, calculate up how much calcium is in that food and then subtract it from this 1,200 milligram. And if there's a number left over, then that's how much you're going to supplement with. So if that's only 500 milligrams or 600 milligrams, then you only need to supplement with 1 tablet of calcium. If you are very consistent with your diet. If you're not, or if you have trouble with your diet, if foods bother you, if you don't get a lot of calcium in your diet, then we try to do the full supplementation. Vitamin D, you can talk to your provider about vitamin D deficiency, is very common. Maybe not down here where it's sunny more than it is up by me in upstate New York, but it is a very common thing. So asking your doctor about whether you need supplementation and if your levels have been checked. So here's some pictures. A little small, well, here's very big, so hopefully you can see this. So I tried to highlight a couple things to keep in mind. So it's really, really important to recognize the serving size. So see how it says 2 caplets? 2 caplets is 400 milligrams. Okay, so make sure you're double checking that the serving size and the strength here, the amount that's in the serving size, match up. Because it's very easy to say like, oh, I see 400 milligrams. Great, I'm just going to take 1. But the serving size is 2, so you'd only be getting half. Same with this one here. So 2 tablets. Oops, sorry, my cursor here. Why is the wire on that part there? Okay, sorry, here we go. So 2 tablets, and then the gummies. So, I don't love gummies for vitamins just because it's harder to get big quantities in there, and some things don't go into gummies. So some minerals they can't put in gummies. So this is 3. So, and I imagine that some of you might have trouble swallowing or chewing gummies. So, but if you do, just again, point is keeping in mind how much is in there. And see, this is a smaller amount of calcium. So, all right, moving on from supplements. So Medications, again, lots of information on this slide. So medications that are used for osteoporosis. So we have our lovely friend, our dentist over here, who's going to be talking to you later. So I'm not going to say anything about dentists that scare you, but dentists sometimes hate these medications because they can affect the bone in the jaw. And that is, some dentists might say, I don't want you ever on any of these medications, or I'm very concerned. But there are ways to safely take these medications, especially if you have dental issues. Oral bisphosphonates, which are drugs like the first column there, or row, is medications that are very old medications like Fosamax, Boniva, alendronate, abandronate, risedronate. These medications are oral, and they have to be taken on an empty stomach, and they have a very, very, very high rate of affecting the esophagus. So I will say, in general, most scleroderma patients should not be on this class of medication because it can irritate the esophagus more. So if a provider prescribes you that, it's important to talk to your rheumatologist about it and find out if they are comfortable with you taking that. Because that oral medication has to be taken on an empty stomach. You have to sit upright. It can still cause irritation to the esophagus. So for the most part, we don't generally use that class in scleroderma. Zoledronic acid, though, is an IV therapy that's very common to use for osteoporosis and scleroderma patients. So it's a once-a-year infusion. It is in this same class where is a bisphosphonate, and we're slowing the turnover of the bone, and that can help with improve bone density. There is a limit to how long we will give these infusions for. So that's something. So you may have heard about the drug holiday. And a drug holiday means that you are on the medication for a little bit of time, and then we give you a break from it. And with this class, this like zoledronic acid, or Reclass is the brand name, that's a very important thing to think about with that. Does anyone know a side effect that you think about when you hear about this class of drugs? I mentioned something with the jaw. Does anyone know what it's called? Osteonecrosis of the jaw. That sounds terrible, right? Say terrible. So it's a very, very, very rare side effect, incredibly rare. There are a lot of risk factors that we know about, so we know how to use it safely. But I'm going to show you a couple things about safety and about statistics of how rare it is. So while dental health is incredibly important, and we know that in our scleroderma patients, osteonecrosis of the jaw associated with bisphosphonates is incredibly rare. So the benefit of taking that medication to help prevent a fracture and improve your bone density dramatically outweighs the risk of having that osteonecrosis of the jaw. These statistics are old. I think this is from like 2007 or 8, but it is more likely to have death by murder than get osteonecrosis of the jaw. It's almost the same as the risk of getting struck by lightning if you were standing in New Mexico. So that is how rare that side effect is. It is, and this is probably, these are outdated statistics, but you see the risk of a hip fracture is very, very high. So I like to put this into perspective for patients because, you know, you hear things from either the internet, the TV, other providers, and it's really important to put this into perspective. If a patient with scleroderma has a hip fracture, we know that's not going to be a great thing. It's going to cause hospitalization and mobility. It can cause more complications. So the risk of a hip fracture dramatically outweighs the risk of this very rare side effect that can happen in the jaw. Here is another thing that it does come up sometimes is what's called atypical fractures. So that's listed here. That's when we know that we know how to avoid that now because we don't keep patients on therapy for 10 years. That's why we give a drug holiday. But again, you can see like an 80-year-old woman who has a osteoporosis in her T-scores, the risk of fracture, of untreated fracture is very high probability, and that risk of osteonecrosis of the jaw is incredibly low. So down there in that 0.01%. So Again, just same thing. I like to use the analogy about we wear our seatbelt, right? So seatbelts help protect us if we get in a car accident. But we don't get in car accidents every day. But if we did and we're wearing our seatbelt, it's going to protect us. So similar idea, if you're not going to fall and fracture every day, but if we have a medication on board that can reduce that risk, that's the purpose of it. So it's reducing the risk of fracture and complicated fracture too. So, all right, so moving on, we'll talk a little bit about denosumab is another medication that's used for osteoporosis. It's an injection that you can get in clinic or the infusion center, and that also slows the breakdown of bone. It is a medication, though. The one thing I want to point out about this medication is that it's not to be given, you're not to be given a drug holiday. So this medication you have to stay on regularly, and there needs to be a plan of if I'm going to come off this medication, what am I going to take next? Because if you don't stay on the medication, you just stop it abruptly, there's actually a risk for some rebound fractures. So it is important to talk to your provider about what's the plan if I come off of this medication. Teriparatide and abaloparatide, these are injections that are used to build up bone. Unfortunately, they're daily injections, so that part can be a little annoying, but we use a lot of this class of medication to help build the bone up, and then we follow it with a medication like the zoledronic acid, and that does a really good job of protecting patients for a while. So we will give these medications. Generally, these are given daily injections for 2 years, and then we will give a dose of either zoledronic acid or switch you over to one infusion of the zoledronic acid or switch you over to denosumab or Prolia, and then we go from there. And these medications can be given again in the future if needed. They used to have a limit for about 2 years, like that was it, but now that limit is gone and we can now give it more frequently. They used to have what's called a boxed warning on it for risk of bone cancer, but that has been removed. There's been lots of studies to support and data to support that these drugs are not increasing risk of bone cancer. So that's something to keep in mind too. Okay, so Evenity is the last medication that I'll talk about. And this medication is a newer medication. It is used it does both. So it slows the breakdown and it does a little building. This medication is only given for 1 year. So this is another option that we could use. The one thing that does scare some people about it is that it does have a warning on it for risk of cardiovascular events. There's more and more literature coming out and safety information coming out to say that this is really a very, very limited risk. But if you'd had a history of a cardiovascular event within the last year, this medication would not be one that we would give. But if you have low cardiovascular risk factors, which you can talk to your provider about, this might be an option for you. And this is given in clinic, like I said, for 1 year, and then we usually will follow it with something else. Okay, so I want to be mindful. 9:45? Yes. 9:45? Yes. Oh, 10:45. Okay. So I've been on Rituxan for several years. How long is it safe to 9:45, right? Okay. I was like, oh, Karen, you gave me a lot more time. I'll kind of go through quickly so that we don't get too off schedule here. Oh, 10:45? Oh, so I do have a lot more. Oh, okay. Well, I might not fill all that time then. I thought I was only talking for an hour. So, okay, we'll be okay. I can answer questions all day. So you can just write them down and we'll go from there. All right. Well, then I'll slow down then. So, how about, what questions do you have about osteoporosis? Yes. 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 Denosumab. Yes. Yes, denosumab and Prolia are the same things. There are now what's called biosimilars. So biosimilars are kind of like generic versions of these medications. Don't ask me all the brand names of those biosimilars. It'll say denosumab and it'll have a couple letters after it. They're all very similar, and they can be used interchangeably at this point. The insurances we've been starting to, they just came to market in the last year or so. So while you might not hear the name Prolia, you'll hear denosumab, which is the drug name. And that's the one that we give every 6 months. So sometimes in my practice, sometimes if a patient knows how to do injections and they can get it through their prescription benefits, we will let them do it at home. But in general, it's supposed to be given by a healthcare provider. So you come into clinic, you get the injection every 6 months, you're scheduled for it, and that's how we do it. That's the one that we have to be careful though. So if you want to come off of it, it's not a medication that we can just stop cold turkey. We want to make sure that we are following it with something if your plan is, I don't want to be on this medication anymore. Because there have been some studies that show that if you just stop denosumab, the benefit of the drug goes down very quickly, like you lose the benefits of the drug, and there's some rare incidences of like rebound fractures. So it is important that what we generally do, we say if a patient doesn't want to be on denosumab anymore, like they're having trouble coming to clinic or there's an issue with coverage from their insurance, we will say, okay, we'll give you 1 dose of zoledronic acid, that IV infusion, and then that one, you can do 1 dose and then be done with it for a while and we don't have to worry about it. Does that make sense? So the one thing that I tell my patients is really, really important about osteoporosis, and if they're not telling you what the long-term plan is, then you need to ask. So when you start therapy with osteoporosis, there needs to be a long-term plan. So what's the plan moving forward? So if I'm going to be on a medication like Prolia, is this the plan forever? Yeah, we have patients that can stay on Prolia for 10 plus years. That's fine. But if I'm going to stop it, what happens next? And then if you're going to be on just zoledronic acid, okay, well, I'm going to take that medication for 2, 3, 4, 5 years. Then what? Because that one needs the holiday. We can't be on it for 10 years. So there is a lot of timing considerations with osteoporosis medications. And then the same thing for those daily injection ones. So they do a really good job of boosting up the bone density, but we can't stay on them for 10 years. So those ones, the daily injections, this one, either Forteo or Tymlos, so teriparatide or abaloparatide, these ones only for 2 years, and then what's the plan? Okay, so if you haven't had that discussion with your doctor, then make sure you're asking, okay, what's the plan after this? And they might say, we'll talk about it next time. That's fine. Next visit, 3 to 6 months, we'll talk about it then. That's fine. But osteoporosis management is a long game. Okay, so there has to be a long-term plan, and you have to be comfortable with that plan and aware of that. So, yes. For osteoporosis? So the question was, who's the best professional? I think that's the rheumatologist. Primary cares and endocrinologists, they can certainly manage osteoporosis. In my area, I would say that primaries are not as comfortable with some of these medications. In my area, I do not see primary cares giving these medications. These are specialty medications. In the world of rheumatology, we are very well versed in specialty medications, and access is one thing, but we are also, in my opinion, we manage most of the osteoporosis in my clinic. So I'd ask your rheumatologist if they're comfortable with another provider in your care team managing it. That's fine. But I think the rheumatologist is the best person in that regard. Other questions? Important that we're thoughtful about the medications that we give scleroderma patients, that we are very thoughtful about it, because I do not like giving a medication to fix something that another medication caused. That's not the goal. The goal is to find a medication that is safe for you, that should not cause negative side effects, and that you can tolerate and be on safely. And if that's not the case, then maybe we need to find a different option. So that's my role. And yes, go ahead.
So with the reclassed holiday, how long does that mean that you can go back on it?
Yes, yes. So a holiday from reclass. So I'll slow down a little bit because I really thought I only had an hour. So with reclass, the way that it's working is it's slowing down the bone turnover, which is good because the bones are turning over too fast. But if we do that for too long, it can leave old bone around too long. And if we leave old bone around too long, it can cause these what are called atypical fractures. That's if we kept you on therapy with reclass for 10 years. So what we found is that if we give you a break from that medication for a full year, it allows the natural turnover to kind of start to happen and get rid of some of that old bone, and then it's safe to give it again, right? So what we will generally do, depending on how bad your T-scores are, so T-scores are the numbers that come out of the DEXA report for osteoporosis. So if it's, if you're negative 2.5 or worse, that's osteoporosis. So if your T-scores get better on therapy, say you've been on reclass for 3 years and you get into that osteopenia range, then we take you off of it for a year, maybe 2 years. And when we do the DEXA again, we see if there's been any changes and we go from there. So at that point, so most patients don't drop dramatically after a year off of the medication. But some people their T-scores don't improve that much on it. And if they don't improve that much on it, that's when we might think about, okay, well, let's do a trial of these medications that will potentially do a better job of boosting up your bone density. I will say, in my practice, we sometimes start with these medications in our newly diagnosed osteoporosis patients. And there is a little bit of data coming out to show that if you start with these daily injections that boost the bone density up first and then give reclass, that long term, there's a better bone density maintainment. So that is a practice that's kind of evolving and starting. I would say that's not everyone. The guidelines for osteoporosis that we don't have in rheumatology specifically, we don't have straight osteoporosis guidelines. It's the Endocrine Society generally that we use. Those guidelines are in process to be updated, so that might change in the next 2 years in terms of which medication are we starting with for osteoporosis.
What do you consider? I think it's on. What do you consider high dose of? You said steroid. A high dose of steroid.
So more than 20 milligrams is generally the cutoff. Well, this is like a rough question. So like in those patients they've had lots of cumulative exposures of much higher doses of prednisone, like in multiple myeloma, like, I don't know, like 80 milligrams of prednisone. In the rheumatology world, usually we'll say like 20, 40, those are like
60 is the highest.
I don't know, 30, 40, 50, those are higher doses of prednisone.
And are we talking about like single dose?
No, like for weeks, months, that's high exposure. If we were to say you had I know the pulmonary folks love to do like 3 doses of 80 milligrams for like an acute flare. At least sometimes I see that. In rheumatology, we don't do that in general. But that's what they do. It's a short burst. It's a short exposure. It gets the inflammation down in the lungs, and then they move on. That's not it's high dose for like a very short period of time. But when we say high dose, and like high doses for long periods of time of prednisone, and in general for scleroderma patients, we're not doing that. Okay. All right. So let's move on. Okay, so I've been on Rituxan for several years. How long is it safe to get infusions? So this is a question I included, and I don't have an absolute answer, but Oh, it went too fast. Yeah. Okay. Sorry. Yeah. So this is a question that is, I don't think we really know the answer to that. We know that there's a kind of a lot of different practices with Rituxan. And there are providers that will, depending on how the patient's doing, they may take you off for a little while. We use Rituxan for a lot of different reasons in scleroderma. We'll use it in overlap conditions. It can help the skin, the lungs, the joints. If you have overlap myositis, so inflammatory muscle disease, if you have very, very, very severe Sjogren's syndrome, where the parotid glands are like clogged up with B cells, which now I think in the next couple of years we'll have better, different treatments to use than rituximab. But there's a lot of different reasons that we use rituximab. So, depending on how you're doing, if you've been stable and your provider feels like, okay, I think, you're stable now, you're doing, a little bit better, we can maybe extend out the dosing interval or do it less frequently. If you were getting frequent infections on rituximab, that's when we're going to say like, okay, well, maybe we need to find another option and maybe this isn't safe for you long term. If depending on the patient's individual scenario, if Rituxan is really the best option to keep you on, but they're getting infections, we can add on immunoglobulin, which can help with the risk of infections. And sometimes we'll do for patients who've been on Rituxan for a long period of time, we will check immunoglobulin levels. And if they're low, it's called hypogammaglobulinemia. If they're low, then we will, even if they're not getting infections, we might supplement with immunoglobulin for that reason as like a protective effect to like help prevent infections. The other issue with rituximab is that there are also now what's called biosimilars, so generic versions. And there are patients that sometimes they've been on it for a while, they get switched to a different version of it, and they might have a infusion-related reaction. So that's something, depending on how severe that is, depending on how they tolerated it, that might be another reason to come off of it or consider other options. So rituximab's a medication that we've been using for a very, very long time. It's been around since like early 2000s. So it's used in a lot of different conditions. It initially was used in oncology, still is used in oncology, but in rheumatology, there's a lot of reasons that we use it, not just scleroderma. So your rheumatologist is generally very well versed and comfortable with rituximab. So any questions about that? Okay. So let's talk about IVIG. So IVIG is intravenous immunoglobulin, so IVIG. It is a medication that can be very, very difficult to get. So the first step is getting the medication. And the next step is, can you tolerate it? Because it is the tolerability of the infusion can be a little tricky. Yes. Intravenous immunoglobulin. So what is it? Yes. Okay. So in our body, we have different types of immune cells, and immunoglobulins are one of them. And they have different roles in the immune system. We really don't truly understand how this therapy works and how it makes patients feel better in rheumatology specifically, but it boosts up and helps the immune system, I would say, just work a little bit more effectively, if that makes sense. You can use it, so prophylactically, so if you have low immunoglobulins, then that can put you at risk for infection. So we know that there's like a correlation there. So like low immunoglobulins, higher risk for infection. Does everyone with low immunoglobulins get infections? No, but because it's a risk, we will supplement and boost up your immunoglobulins to prevent the infections potentially. In scleroderma, so with the reason that we use this is that, so one, to help with infection, so that can be one thing, but there is actually benefit in a lot of different other areas. So although the problem with studying this drug is that There are a lot of different formulations of it because it's made from donor blood plasma, and it's a somewhat difficult. It's difficult to study because we're using it in a patient population that has a lot of differences. So we call it like heterogeneous. So like if you have a group of patients who all don't look exactly alike, all of their symptoms are not exactly alike, it's hard to study that population because what is your outcome measure that you're looking at? So if everyone looks different, but they have the same condition and their symptoms are different, what is our outcome that we're going to look at and try to see a difference in? It can make it a little challenging to do that. So that's one thing. In terms of myositis, so there is some good studies. So sometimes patients with scleroderma will have overlap inflammatory myositis or muscle disease. And there is a study, and this drug is approved for what's called dermatomyositis, a form of this inflammatory muscle disease. And that's kind of one of the best kind of evidence that we have in rheumatology. So that's one thing. There is small reports of IVIG helping with the GI tract. Anecdotally, I would say some patients do feel better from their GI tract. The problem is that because the studies are very limited and it's really just case reports almost, or case series, it's very, very, very hard to convince the insurance to pay for it because they consider it experimental. If a patient has overlap conditions that the provider feels that they could use that as a justification too, we try to argue that. But I will say this is one of my most difficult problem child medications to get covered and get access to for patients. So that's one thing. So if your doctor says they want to maybe use it, I hope that right after they say that is, it's not going to happen fast, and we're probably going to have to fight with the insurance to get it. So that's something. So don't expect, it's not like you can get it in a couple days. Honestly, getting Rituxan is easier than, Rituxan and Actemra, tocilizumab, those drugs is easier to get than this one. Yes. Yes. So in terms of, so this is something I do on a daily basis, not just for my scleroderma patients, but all of my rheumatology patients. So the first step is that you submit the prior authorization to the insurance. In this case, it's covered under medical benefits, so it's not pharmacy benefits. And the insurance will say you have to submit it with a specific diagnosis code. And if the insurance recognizes that diagnosis code as a reasonable, acceptable use, which I have a couple slides on this later, but they will say it's in their formulary, in their algorithm, that yes, this medication can be used for this patient population, they will approve it. If they don't, if they say, oh, we don't recognize this is experimental, we don't know, we don't think that there's enough literature to support using this drug, we need your doctor to tell me why. Show me the evidence. So one of my strong suits is showing them the evidence. So I will put together letters of medical necessity that highlight all of the studies that have been shown to provide benefit, and also provide an argument that says, this is why there's no other medication on your list that is acceptable for my patient. So it's both justifying why no other medication is a good option that they want us to use, like no cheaper option, and then summarizing all the literature that goes into support why we want to use this. Depending on how strong that literature is, it still might be a fight. So then they might deny it again. You have the legal right to appeal it a second time internally with your insurance plan. And then if they deny it again, and that at that point, it generally goes to a medical director, like a physician that's working for the insurance company. They may or may not have rheumatology experience. They may have never heard hopefully they've heard what scleroderma is, but they may not have any relevance to the disease, but they're deciding, is this strong enough evidence? And then if that's denied, that time you have the right to go to what's called external appeal. An external appeal is generally at the state level, and you will submit, like depending on what state you're in, we have this very long paper form that I help my nurses fill out. And we, again, provide all that evidence, and it goes to a third party outside of your insurance plan, and as someone who specializes in rheumatology looks at it. That process is not fast. So this is like, we're now getting into like month 2, 3 of fighting. And then if that person thinks it's reasonable and enough evidence and that there really is no other option, then they can overturn the insurance's plan. I will tell you, not all practices, not all doctor's offices, practices, clinicians have staff and or bandwidth to do that. So it's something that you may have to kind of wade your way through. But in rheumatology, I would say we're fairly used to this because all of our drugs are expensive. So it's not just our scleroderma patients that are going through all this. So, okay, so immunoglobulin. So we use it for a lot of different things. There are listed all these different FDA approved indications. And then here is a list of all the different things that conditions that we use for it in rheumatology. Like I mentioned, in scleroderma, we'll use it in patients primarily if they have overlap myositis, if they have low immunoglobulins that we're worried about infection, if there's overlap in neuropathy sometimes. And like I said, sometimes we can get it for gastrointestinal disease. I have found that there are different companies that specialize in IVIG, home infusion companies. There's one called Kaba Fusion, which I have no disclosure, no money paid from anything with this company. I have just found them to be very helpful. They're all over the country. They kind of specialize in IVIG, and they will help with the authorization and help fight the fight. So it's another layer of resources. They have pharmacists that will, like me, that are doing that with that company. So that can be another resource for you if this was a medication that you needed to fight for. Now, the next thing about this drug is its tolerability and how it's given. So if we're doing it at home, the home infusion company will come in and give the medication in the home. The nurse comes in and does the infusion in the home. The tolerability, so the way that the drug is given, depending on your dose, it's weight-based dosing, and sometimes there's dosing differences based on the indication that we're using it, but it's given over a consecutive few days. Generally, it's 2 to 3 days, but if some patients might need it over 5 days. And that happens, if you're doing it intravenously, that happens once a month. So you're getting 3 days worth of an infusion, 3 or 4 days sometimes, every month. So that's a commitment. Yes, so this is a commitment. It is a lot to do. If you were to go to an infusion center, again, that's a lot. That's another part-time job to do that. So if that's why the home infusion is helpful, because they can come in and you can do it in your home. They have nurses that they'll be with you the whole time. The other issue with it is tolerability and vein access. So in our scleroderma patients, sometimes we have difficulty getting blood draws and difficult venous access, so vein access. So that's another problem, because if we're doing this for 3 days in a row, that means we need to get a vein and do the infusion 3 days in a row. That can be a challenge. And then the third part is tolerability. So like it's very likely that you will get a headache and not feel well after the infusion. So we call it infusion reaction. So we give pre-medications. So like I said before, I don't love giving medications to prevent side effects, but in this scenario, we have to. So it can cause headaches, some nausea, a little bit of flushing. So we might give other medications with it. So this is a commitment, and I think it's important for it's not like yep, I'm going to go pick up my IVIG from the pharmacy. It's not a simple process or simple treatment. It can be very helpful, and I have patients that feel really great after they've been on it for a few months. But it's a commitment to get it, and then to get it covered, and then to also get the infusion. There are options for subcutaneous. I think I have it on the next slide. Yeah, so this is, okay, before I get there. So if So then the other question I'll get is, if I need this medication, I'm also on on other IV medications, should I get a port? So that is, again, a challenging question because that opens you up for more infections, clotting. So that's a big discussion too. So again, there's a lot of layers that go into deciding some of these things. Honestly, in my opinion, I would rather switch patients over to what's called subcutaneous immunoglobulin before having them get a port, unless it was like there's a really strong other reason for them to get a port. The subcutaneous immunoglobulin, so this is very interesting and different. There's not a lot of medications that are given like this, but basically what it does is it takes the infusion and it's infused into the sub-Q tissue. So like what happens is, and did I put a picture? I didn't put a picture, I'm sorry. So what happens is they have these little, has anyone seen like a diabetes pump, like an insulin pump? Okay, so think about an insulin pump that has 4 prongs, so 4 little needles, and it goes either on the outside of the thigh or top of the thigh or the belly on each side. So it's got like 3 or 4 little needles that go in, and then there's tubes attached to it. And then that is attached to what's called like a infusion cassette pump. And that medication is then slowly infused into that sub-Q, that fatty tissue, over hours in one day. And that you do that at home, and they teach you how to do it. And then that happens once a week. So if I've deterred anyone from wanting to use this medication, I'm sorry, but but I think it is really important for you to be aware of all of the logistics and everything that goes into it. So so that's an option if the IV is not tolerable. I do have patients that have been on sub-Q immunoglobulin for a long time, actually. I have a pregnant patient actually on it right now, not with scleroderma, but yes, what's your question?
How long do you have to take this? Once you started, is it once every month, every 5 months?
Yeah, so the IV form is every month. And again, we'll have patients do it monthly for maybe 6 months, and they will feel better. And then we're like, okay, well, let's see if we like skip a month, how do you feel? There are patients that will do the sub-Q, it's every week. So like I have a young, she's a dermatomyositis patient. So she's been on it, the sub-Q version for a long time, like years. But she's also pregnant now and going to come off it for a little while. She has gotten it like taken little breaks off of it, but because of her specific condition, she has failed all of the other options, and this is the best one that's worked for her. So, yes.
Does this have any correlation to the Actemra? Or they're 2 different things?
2 different things. So the Actemra is you can do IV or subcutaneous tocilizumab. So that is a different drug that's working on an inflammatory cytokine or protein in our body called interleukin 6. That interleukin 6 has been shown to have some effects in the skin and the joints and in the lungs. So if we block that protein with tocilizumab or Actemra, it can help you feel better, and you can see improvements in skin, joints, and lungs. So that's separate than this medication. So this is just immunoglobulin. So replacing immunoglobulins, which has some, again, we don't truly understand how it works, but helps the immune system function a little bit better in general. So less specific than tocilizumab. So any other questions about that?
So you needed stuff.
Yes, I am glad. This is a pleasant surprise to have more time. I really thought I only had an hour, Susan. That's okay. No, I'm happy to have more time because this is actually so much more enjoyable to me than having to rush through some slides. I love being able to answer your questions and talk about this, even though it makes me a little uncomfortable because I don't know any of, I've never looked at any of your charts. So that, that's a little tough, but yes. So, okay. So we're going to switch gears a little bit and talk about access and a couple things. And I know this is going to open up a lot more questions, and I hope I'll do my best to answer some of those. But so if you don't have Medicare already, then this might be new information for you. If you do already have Medicare, this is probably not new, and you probably already know all this, but I'm going to just kind of back up and explain it in a little bit more of a detailed way. So in 2025, so last year, the Medicare Part D, the Medicare coverage, so Medicare Part D coverage, which is the prescription benefit coverage, changed. Well, all of the Medicare coverage changed. And I am not a Medicare expert by any means, but from a busy clinician's perspective, I'm going to simplify it for you. So prior to 2024, people with Medicare had a deductible, so it was like $3,300 or something around that. And once you got through that $3,300 deductible, you got into this initial coverage phase here. And then if you did not have what was called gap coverage and you hit what's called the donut hole, so if you're on a very expensive medications and you get through this, you get here and then you have no coverage for the medications until you get to what's called catastrophic. And don't ask me what the numbers were for this because I don't know, it's irrelevant now, but this was the old model. So you hit the donut hole. What is my all this? You hit the donut hole and then you had to pay a lot of money to get access to the drugs, or you had to be on what was called patient assistance programs. Now in 2025, they made changes. So they dropped the deductible. So this is 2025, but now it's 2,100. And the deductible, and they removed this coverage gap. So there's no more donut hole. So now the plan covers medications after you get through that now it's $2,100 deductible. So that's still a lot of money. So I'm glad you brought up tocilizumab. So what happens is if you have Medicare Part D coverage, you don't have any supplemental coverage for your medications, then you have to pay this $2,100 deductible at the beginning of the year. There is a payment plan option, which we'll talk about. But say you are a scleroderma patient with Medicare, you are on tocilizumab or Actemra subcutaneously, and it is January, and that medication, if you were to go fill that medication under your insurance through Medicare Part D, the copay that comes back is going to be about $1,500. Okay, right? Okay, good. Same here. Good. And that means that you have to pay that $1,500 for that first dose. And then the next month, whatever was left over, so that like $600 would be your next copay. And then the third month, no copay, covered. Okay, so that's kind of how it works. You get through the deductible. I don't know about you, but I don't really love the idea of forking over $1,500 in January for one prescription. That's like a tough sell. Okay, so what they did was they implemented this payment plan. So this caused all sorts of problems because it was very confusing. And what happened, but it's a good idea, I think. So what it's called is it's a Medicare prescription payment plan, and the individual has to sign up for this payment plan, and it spreads that deductible out over the whole year. So instead of paying that deductible up front in January, February, if you're on high cost medications, then it spreads it to, it's like 178 now. It's more, it's a little bit, or yeah, 175 now, over the course of the year. So you pay $175 a month every month, and that's not to the pharmacy, it's directly to Medicare, and you get like an invoice every month, and that's how you pay it. So the problem that happened for a lot of my patients on tocilizumab specifically was that because they got rid of this gap coverage and that higher deductible, all of the companies that had patient assistance programs, they dropped their annual income threshold. So if you qualified prior to 2025 for a patient assistance based on your annual income, in 2025, you may not qualify anymore because they dropped those thresholds. So that happened a lot with my patients because then they couldn't afford their tocilizumab anymore. The good news is that for some patients, if they couldn't afford the deductible, they couldn't afford the payment plan, and they still needed to be on tocilizumab, we are able to give intravenous tocilizumab that's covered under medical benefits. And that was kind of our way around this. And the copay for those infusions was less for patients it was around like $50, $60 a month or something like that. So that was more reasonable for a lot of patients. So that was good because we had that alternative. With tocilizumab, we have both sub-Q and IV. Not all medications we have that option. So, like I said, I'm not a Medicare expert, but the other issue that I have with this though is that it led to gaps in access. So patients who were on tocilizumab may not have gotten their tocilizumab on time. They may have had a delay where they couldn't get it filled or they couldn't get it. So that was an issue. I feel like this year has been a little bit easier transition because now we went through that first transition and patients are more savvy and know, but it still is it's still a problem. It still comes up. I mean, this actually just came up for a lupus patient of mine. It's a very similar scenario. We're having to switch her over to a IV infusion that she's been doing well on a sub-Q for a long time. So it's not ideal, but it's what we had to do. So, okay. So questions about that? Any questions? Oh, good, because I don't know that I'd be able to answer that, but that's my extent of understanding. But logistically, this is kind of our options right now with Medicare. Okay, so the next thing I want to do is talk about off-label and FDA use, because I think it's really important for you guys to understand this. So there are medications that are what's called FDA approved. So the Food and Drug Administration approves them for certain indications, meaning like high blood pressure, that hypertension, that is an indication. So there are medications that are approved for hypertension. There are a couple medications approved for scleroderma. However, it is generally the ones that we do have approved, it's scleroderma ILD, so interstitial lung disease. So if you have just scleroderma and you don't have lung disease, and we want to use this drug like tocilizumab that's approved for scleroderma ILD, you don't have ILD, you just have scleroderma, that is considered off-label. And what that means is that the insurance is not going to recognize it as an approved use easily. There are ways around it, like we talked about a little bit about, but there are some conditions that are recognized by Medicare as off-label. And this is you as a patient, it does not have access to this, but there are different databases. So there is the NCCN is the oncology database and like recommendations, so that's kind of separate. But there is a database called Micromedics or the Drug Dex. And then there is another reference database that's called AHFSDI, which is a American Hospital Formulary database, which that terminology is kind of outdated. But either way, it's a database. And if it's listed in there as off-label, like recognized off-label, then the insurance will pay for it. And the third one is Lexicomp Drugs, which if anyone is a very common database that many healthcare clinicians have access to, but it has to be listed as level A evidence. So these are their requirements. So Drug Dex, I'm going to show you what it kind of looks like. This is small, but well, it's big up here, sorry. So when you pull up a medication like, so I have tadalafil. have tadalafil over here. So this is a medication this is LexiComp drug. So in LexiComp drug, which anyone who works for MUSC probably has access to, like clinicians, so doctors and providers, they have access to up to date, which is, and Lexi drug is embedded in there. So in this monograph, so this database, it does not list Raynaud's for off-label use for tadalafil in this database. In Micromedex, which is a separate database that Medicare recognizes, it is listed. So what this means is that when it's not an FDA approved indication. So the first time we submit a prior authorization to pay for this drug, the insurance is going to say, no, it's off label. But then when we appeal it, we say it is a recognized indication and there is literature to support it. Micromedex says it's an FDA or it's an off label recognized indication. They will pay for it and they will cover it. So this is similar to and rifaximin, I would say, is, small bowel bacterial overgrowth is listed here. So technically we should be able to get it covered. So getting it covered, though, doesn't mean that you're not going to have a high copay if you haven't met the deductible, though. So that's the other piece. So it can be covered by the insurance and they're going to pay for it, but you may still have to meet your deductible. So there still could be a high copay. We're on the same page? Okay. So these are some resources that, you could ask your clinician, like your provider, especially if they're not in an academic institution. I will say in general, most physicians do not know and do not use Micromedex. So like Dr. Silver will call me and ask me, Jessica, is this covered? Is this recognized? So, but this is how, so for those of you who don't know, the reason that Cellcept or mycophenolate is covered for scleroderma is because I submitted on behalf of the Scleroderma Foundation literature review and asked the editorial team of Micromedex to add it as a recognized indication. And then you're welcome. So before that happened a while ago, before my daughter was born. That's how I remember things. So so that now we don't have to fight for them to even say like it's not recognized. It's recognized. It's in a recognized database. So I just wanted to explain that because I think that if you don't have a pharmacist that's part of the team, this is like a very nuanced thing that is not knowledge to every clinician. So just keep that in mind. Okay, the last thing I think I have to talk about, and then I can take more questions, is just different resources for medications. So there are a couple different things. So there's GoodRx. So most people in the room are probably familiar with GoodRx, right? I will say that most like commercial like pharmacies like CVS, Walgreens, Rite Aid, like some grocery store pharmacies, they will take these coupons. If you use a like mom and pop, like an independent pharmacy, they'll actually probably lose money on this. So they'll probably, if they do use the coupon for you, they're being very kind, but they're probably going to lose money on it. So they might send you to another pharmacy if you're going to use these. So it's happened to me with an EpiPen because I had to get allergy shots, and my pharmacist is like, I'm really sorry. Can you go get it filled at Hannaford down the street, the grocery store pharmacy? Because I'm going to lose like $75 on this. So I think it's good to use a independent like mom and pop pharmacy because you're going to get better service, better care. They're going to know you better. But there's some scenarios where they might lose money on your prescriptions. So that's one thing. There's an app, there's different, it will list, like if we looked at tadalafil, I mean, honestly, for a lot of our Medicare patients, if they're not on other expensive medications, it's usually cheaper for us to use the GoodRx coupon for tadalafil than it is to go through their insurance. So that's something to keep in mind. The other thing that I have not had much experience with, but is this Mark Cuban pharmacy. Has anyone used it? Yeah? Okay. I have not personally sent patients here. The one thing that's not great about it is that it doesn't have every medication. So like there are medications that you can search for and they just don't come up. So, but this is an option. Your provider could send a script to this pharmacy, and I do have colleagues that use it. So this is a, you know, much cheaper option. So, so you can play around with those two sites based on your medications and cost things out, but those are two things that are available to you. And then the last thing is, which I think, I don't even know what to say about it, honestly, but this Trump RX is just dumb. So I will say that. Politics aside, who cares about brand name drugs that still cost $1,500? I'm not really sure how that's helpful. I appreciate the thought that like, okay, let's give more access to people, but it's only brand name drugs. They're still very expensive, and there's only like a handful on there. So I don't know what the purpose is to help the general population, but if you want to get Wegovy, I guess it's maybe a little cheaper. I don't even know. So that it's really not, at this point, current state of affairs, not helpful. So don't even bother. But other resources, there's a couple different databases that you can use. Needy Meds is a good resource. It's like a full database that has a list of all different patient assistance programs and coupons. So it's a little clunky to kind of like sort through, but if you put in your medication into the search bar, it'll then give you kind of a list of what options are for patient assistance. It might be manufacturer coupons. It might be different foundations. The PAN Foundation, which is listed down here, is a good resource. But there are only certain grants in the HealthWell Foundation. Depending on the disease state, depending on the drug, the window for when they can accept applications for coverage is short, or they might not have funds. So it's something that you kind of have to like check back and forth on. I have a team that helps me with this. Like I don't do these applications on a general basis, but I'm aware of them because I have them checked. Like they know to check to see like, oh, does HealthWell have a grant for my patient to cover their auto injector methotrexate, which is one that's tough to get covered for some, or cost-wise for some Medicare patients. So there's windows when it's open and you can apply. So there is that, and I'm done. So